Thank you, Mr. Gonzalez. Thank you, Chairman and members of the committee. Thank you for holding this hearing. I'm here today on behalf of AdvaMed, the Advanced Medical Technology Association. 70% of our members are relatively small companies with sales of less than $30 million a year. The company I work for, KCI, is a medium-sized company today, but it started out as a small family-owned business 30 years ago, so we understand the role that small, innovative businesses play in driving progress. Our message today is very simple. Advanced medical technology is a smart investment for patients and taxpayers alike. Medical innovation saves lives, it improves patients' health, and in doing so, it very often saves money. For example, by allowing patients to be at home as opposed to being in the hospital. As doctors like to say, the most expensive equipment is the one that doesn't work. That's why we're concerned about the design and implementation of CMS's competitive bidding program. Specifically, we have three concerns relating to product interchangeability, cost savings, and supplier capability issues. Regarding interchangeability, as you know, CMS has chosen 10 specific product categories for this program. I want to share you two of these are walkers and negative pressure wound therapy devices, which are depicted here on the slide at the very back of your packet. Some of you may have seen that. Competitive bidding treats both of these product categories the same way, yet obviously they're very different. One product is a simple functional device that helps you walk, hence the name walker. It's pretty straightforward. The other product category is negative pressure wound therapy, a category created by CMS that includes KCI's VAC therapy. VAC therapy is a complex, sophisticated therapeutic system that's used to treat some of the most severe and hard-to-heal wounds, often in highly compromised patients. So, for example, a typical patient who relies on this type of treatment is a diabetic who has comorbidities such as obesity and hypertension and may be at risk of an amputation due to poor blood circulation in the arms and legs. VAC therapy reduces swelling, prepares the tissue for healing, and removes toxic fluids. So as you can imagine, this is a technology that significantly reduces healing times, reduces infection rates, prevents amputations, and shorten or eliminate hospital stays. Basically, the VAC is proven to save lives, limbs, and money. Yet starting on July 1st, because of a flawed competitive bidding program, Medicare will deny access to this therapy for elderly, disabled Americans living in these communities. Now, this loss of access wouldn't be so bad if all offerings in CMS's MPWT category were interchangeable, like walkers, but that's not the case. VAC therapy is unique and not clinically comparable with other products. In fact, only VAC has scientific studies to prove that it produces the positive effects that I described a moment ago. We wheeled in some of the paper, the clinical studies, the peer-reviewed journals, the appointments in different medical books, and it took quite a job to get that in. You'll see it on the table behind me. But VAC therapy has the largest body of clinical evidence in virtually any wound care product, and it's why VAC therapy is the only product cleared by the FDA specifically for use in the home, and it is why our military forces in Iraq use the VAC exclusively for the severe, complicated wounds that they treat every day. Physicians and medical societies, including the two nation's largest wound care associations, told CMS that products in the MPWT categories are not clinically equivalent and that the category shouldn't be competitively bid, but the agency didn't listen. Our second concern has to do with the claimed cost savings of the program. CMS estimates competitive bidding will save 20% in all product categories on average, but the estimate only looks at line item prices. As suggested earlier, you also need to look at outcomes and total cost to determine the true value. Unfortunately, Medicare officials only plan to look at line item price savings. Here again, the VAC provides a good example of why this is penny wise and pound foolish. A study of Medicare patients treated with VAC therapy in the home found the patients had lower rates of hospitalization, lower need for emergency room care, as well as less pain and a higher degree of mobility. And when compared with patients who were not treated with the VAC, patients treated with the VAC at home had average cost savings between $3,600 and $12,000 per patient. Again, those savings were not factored in. Our third concern has to do with the clinical support. Patients using therapeutic equipment require training to ensure that the products are used safely and effectively. They and their caregivers also need access to clinical and technical support 24 hours a day, 7 days a week in case complications arise. And without this, patients could be jeopardized. Many NPWT contract suppliers appear to lack sufficient capabilities to provide an acceptable level of patient support. We know many of them fail this test because a number of them contacted KCI inquiring whether they can obtain VAC supplies from us and revealing that they have no experience with this therapeutic category, no supply of product, no guaranteed access to supply, and no clinical or customer support capabilities specific to the therapeutic option. So in conclusion, we believe competitive bidding, as designed and implemented by CMS, suffers from serious flaws that should be addressed before the program goes forward. And finally, in sophisticated product categories such as this, we believe that CMS is fooling itself if it believes that low bid prices will reap lower costs. Just the opposite. There will be costs. Those costs won't come in dollars, but rather in lost limbs and in quality of life. And in the long run, Mr. Chairman, members of the committee, we feel superior outcomes, not price alone, will save money.